Hi, I'm Sasha Ayad. It's January 2025, and here's what's on my mind this month. The false assumptions of gender medicine. One of the most prominent advocates for pediatric gender interventions, Dr. Johanna Olson-Kennedy, is being sued by a former patient for medical negligence. And by looking at the details of this lawsuit today, we'll notice 7 false assumptions that are often found in pediatric gender medicine, which harm patients and feed into this serious medical scandal. Today, we're going to look at 3 of these bizarre, distorted assumptions so that you can spot them, steer clear, and adopt a reality-based understanding of gender distress. And in February, we'll review the others. Before we get started, I highly recommend that after you watch this video, you go read the original reporting by Jesse Singal, who broke this story for The Economist. He's been one of the bravest and most meticulous journalists covering youth gender medicine. And I also referenced the work of Ben Ryan for this video, whose Substack is excellent, and he covers news on this topic in great detail. Let's get into it. First, I want to tell you a bit about Dr. Johanna Olson-Kennedy. She's an adolescent medicine physician, and since 2012, she's been the medical director of the Center for Trans Youth Health and Development at Children's Hospital, Los Angeles. This is currently the largest and most well-known youth gender clinic in the U.S. In 2015, she also received $10 million from the NIH, or National Institutes of Health, to study outcomes of using puberty-blocking drugs on youth. She has admitted to withholding the findings, but then she changed her story, and we'll look at that a little bit more next month. She's also a prominent member of WPATH, and she's the president-elect of their U.S. branch, USPATH. So clearly, Olson-Kennedy is a well-known figure, not just some isolated radical. Though I do know she's considered pretty extreme even by some other gender-affirming doctors and therapists. Nevertheless, she is regularly quoted in major media outlets and has served as an expert witness in many cases, especially against states implementing state bans, in which she advocates for youth to receive these interventions. She has reported giving cross-sex hormones to children as young as 12, and she's recommended mastectomy for 13-year-olds. Olson-Kennedy is named in the suit along with 2 others, a surgeon, Dr. Scott Mosser, and a licensed therapist, Susan Landon. Now we'll take a closer look at the details of the suit and learn about the plaintiff's account of events. Before we get into it, I actually need your support to keep producing material like this. If you think this video is helpful, please consider becoming a paid Substack supporter. As of now, my newsletters and my What's on My Mind videos, like this one, are completely free, but they do take significant resources to produce, so becoming a paid supporter really helps me out and my team. I'll leave a link below. Okay, the plaintiff is 20-year-old Clementine Breen, who was first seen by Olson-Kennedy when she was only 12 years old. Breen claims that her mental health was not considered or managed properly, that there was a serious lack of gatekeeping, and not enough concern at all about the impact that puberty blockers would have on her bone health, and that all of this amounts to medical negligence. In interviews, I've also heard Miss Breen share another reason she wanted to bring this lawsuit. Many people say that no one is rushing kids into gender medicalization. They say that the process to receive puberty blockers, cross-sex hormones, or surgery is always very slow and careful. But what Clementine has been through demonstrates that this is simply not true. And she wants people to understand that. And as you'll hear, from the moment she began seeing the gender therapists and the doctors named in the suit, Miss Breen was rushed into irreversible medical interventions with lifelong consequences. We'll start by looking at Clementine's initial referral to Dr. Olson-Kennedy's gender clinic, which highlights for us false assumption number 1, that discomfort with your biological sex always means you should transition. Clementine began to feel uncomfortable being a girl around age 11. Prior to this, there had been a violent incident with her brother who has a severe disability, and Clementine had experienced sexual abuse at the hands of someone outside her family when she was a young child. Then, while she started going through puberty, she became unsure of her identity, her sexuality, and started to wonder if she might be transgender. By age 12, Clementine thought that life just might be easier as a boy. Now, she had shared this distress with a guidance counselor, not Landon, who latched on to the transgender bit. The counselor told Clementine's parents that she believes their daughter is trans, And then with encouragement from the school and the family, Clementine's name and pronouns were changed. Then Clementine's first appointment at CHLA with Dr. Olson-Kennedy was in December of 2016 when she was 12 years old. Before we get to the content of that first meeting, I want to point out an important concept called diagnostic overshadowing. This happens when a person's distress and symptoms are all attributed to one specific diagnosis, while other mental health or medical issues are overlooked. I'll give you a simple example. Let's say a patient is known to have an anxiety disorder and he starts experiencing chest pain. Then the doctor believes that anxiety is the cause, when in fact a real cardiac event like a mild heart attack or stroke has taken place, but has gone undetected. So in this example, the anxiety diagnosis overshadowed the cardiac event. And in the case of Clementine and hundreds of other kids like her, the guidance counselor heard about a variety of difficult circumstances and past experiences she had. But of everything Clementine shared, the trans kid part became the most salient. Maybe this happens because it all feels a bit exotic. Maybe the counselor also worries that gender questioning kids are particularly vulnerable and need to have the gender issue addressed right away. Either way, the novel gender identity takes precedence over other very commonplace life stressors. And at this early stage in the process, Miss Breen didn't actually qualify for a formal gender diagnosis at all, making it even more remarkable to see this diagnostic overshadowing at work. Any utterance of trans dramatically shifts the professional's clinical behavior. And of course, that continued to happen at the first appointment with Olson-Kennedy and with Landon, who is the therapist that Olson-Kennedy recommended to Clementine. In the following brief clip, Clementine describes her first 30-minute appointment with Olson-Kennedy to Billboard Chris. He asks whether or not her previous traumas were explored before puberty blockers were recommended when she was 12 years old.
Before you started on the puberty blockers, you've just shared with me this sexual abuse that happened to you before you started on those?
Yeah.
Did anyone ask you about that?
No, not was that brought up once during the meeting. I was only asked, do I like hanging out with boys? Do I get fit in better with boys? What kind of things am I into? Just really surface level questions. And I was prescribed puberty blockers 30 minutes into my appointment after being out for 4 months.
Wow. Even in Olson-Kennedy's notes from that first session, she wrote that Miss Breen had only been out as trans for 3 months, but also wrote that she met the criteria for a gender dysphoria diagnosis, in which a cross-sex identity has been present for 6 months or longer. That seems like a contradiction, right? Why wouldn't Olson-Kennedy simply recommend for Breen to come back in 3 or 4 months to see if the trans identity persists long enough to make that 6-month mark? Well, let's revisit that false assumption again. Discomfort with your biological sex always means you should transition, right? Any cross-sex identity for any duration means you're trans. In my work as an expert witness, I've reviewed cases just like this, and I've always been baffled by how quickly things change the second a child announces that they're questioning their identity or experiencing discomfort with their biological sex. It's like a light switch, and you can see it in the doctor's or therapist's progress notes. For months, they're relating to this patient like a typical teenage girl. But the second she mentions some vague discomfort about her sex or questions if she might be trans, suddenly, like magic, the clinician quickly switches modes. And everything thereafter becomes about validating the trans kid and sending her to trans support groups and getting her a binder and getting her sent off to a gender clinic. It's swift, it's immediate, and I find it quite robotic and disturbing. It's almost like the clinician becomes hypnotized by mention of the word gender. And we see the same thing happening here with the guidance counselor and, of course, later with Olson-Kennedy. So in that first meeting with Clementine, Olson-Kennedy orders puberty blockers and writes in her notes that she doesn't suffer from any psychiatric comorbidity that would interfere with a diagnostic workup or with the recommended treatments. But how does she know this? She'd only met with her once and for less than 30 minutes. And more importantly, she hadn't asked any questions about psychiatric comorbidities. Maybe it doesn't matter if discomfort with your biological sex always means you should transition. Now I want to look at false assumption number 2. Bodies have nothing to do with identity, and bodies don't matter. Gender doctors often prioritize vague and esoteric internal identities while treating the real flesh and blood body like an object we can easily modify. It's like a Mr. Potato Head view of the human body. We'll just elevate some hormones here, remove some body parts there. But the physical body can't be changed so drastically and in these particular ways without serious health consequences. And at the same time, distress, ambivalence, or questions about identity are treated as immutable, concrete, and the very thing to be actualized by these medical interventions. This doesn't make a lot of sense given that our identities are complex and they evolve over time and they're malleable to so many factors and contexts. Why would we physically harm a healthy body based on an internal perception that could be fleeting or temporary? A potato head doll has interchangeable plastic parts, but we are human beings, and it seems that many gender doctors and surgeons don't make this distinction. Olson-Kennedy, when defending early interventions for kids like mastectomy or breast removal, once famously said, "If you want breasts at a later point in your life, you can go get them." While treating Clementine, Olson-Kennedy's notes included contradictory statements about the duration of her dysphoria, too. She even wrote that she had been endorsing a cross-sex identity since childhood, when it was clear from other parts of her notes that that's just not true. I guess if identity is malleable and may change, you can always just lie and pretend that a patient has had a stable, long-standing male identity. So 6 months after starting puberty blockers, it was recommended that Clementine start testosterone. In the lawsuit, she reports that she was reluctant, but that Olson-Kennedy told her beginning earlier would help her pass as male. So the conveyor belt of medical interventions continues. Next, when Clementine was still 13 years old, Olson-Kennedy and the therapist, Susan Landon, wrote referral letters for her to see surgeon Dr. Mosser to remove her breasts. Now, I want to dig a little bit deeper into this very flippant treatment of the body and see how the body is used as a vehicle to actualize identity. Okay, so as a thought experiment, let's just say that Clementine actually met the diagnostic criteria, and let's say she'd been severely gender dysphoric and expressing a cross-sex identity for many years. Still, and actually by definition, she could only wish to turn her female body into a boy's body if she had a female body. Being female is a necessary condition to having the fantasy of becoming male and of having FTM gender dysphoria. This would mean that Clementine is grappling with the real distress, events, circumstances, and embodied experience of being female. It seems like such a simple fact. How could this simple fact be glossed over so easily by gender clinicians? Wouldn't it be of crucial importance to discuss Clementine's female embodied distress and try to understand it? Instead, so many gender doctors operate as though we are just disembodied identities that somehow got put in the wrong body, that we've had our sex assigned at birth. But actually, we are our bodies, and our bodies are sexed. And we have no option to experience consciousness or any other aspect of our lives outside of our sexed bodies. To demonstrate how pervasive this mind-body disconnect is in the perspective of Olson-Kennedy, I want you to listen to this clip during a conference where she tells the famous PopTart story.
Yeah, you have to hear the PopTart story real quick.
I think people have heard. Have people heard the PopTart story? Yeah. Okay. Well, often because I only work with youth, I don't work with folks that are over 25, but an 8-year-old kid that came into the practice, and the story for this kid is assigned female at birth. Hang on, I've got to swallow my Tic Tacs. This is why I don't have legitimacy in this work. Okay. I love that you're all laughing. So this kid comes into my practice, and this is the entire reason why. This was an assigned girl at birth, 8 years old, was completely presenting male, whatever that means. But, short haircut, boys' clothes. But what was happening is this kid went to a very religious school. And in the girls' bathroom, which is where this kid was going, people were like, why is there a boy in the girls' bathroom? That's a real problem. And so this kid was like, so that's not super working for me, so I want to figure out, like, I think that I want to maybe enroll in school as a boy. Like, this kid had come up with this entirely on their own. And so, you know, when the kid came in, the mom was like, oh, we don't know what to do, you know, please help us. And so we started talking about it. And what was interesting is that, you know, some kids come in and they have great clarity and great articulation about their gender. They are just endorsing it, and this is what I am, and yes, there's gender confusion, but it's all of you who are confused. And so there are those kids. So this kid had not really organized or, you know, thought about all these different possibilities. And so at some point, after this kid had told me, you know, the mom had shared this whole history, had said, like, when this kid was 3, you know, my kid said, could you know, stroll me back up to God so I could come back down as a boy? And the kid was like, I didn't say that, you know, 8 years old. So I was like, I don't think your mom made that up. That's crazy. So anyway, so this kid, at one point I said, so do you think that you're a girl or a boy? And this kid was like, I could just see, like, there's just confusion on the kid's face. Like, I'd never really thought about that. And so this kid said, well, I'm a girl because I have this body, right? This is how this kid had learned to talk about their gender, was based on their body. And I said, and this is, I completely made this up on the spot, by the way, but I said, so do you ever eat Pop-Tarts? And the kid was like, oh, of course. And they said, well, you know how they come in that foil packet? Yes. I said, well, what if there was a strawberry Pop-Tart in a foil packet in a box that said cinnamon Pop-Tarts? Is it a strawberry Pop-Tart or a cinnamon Pop-Tart? Kid's like, duh, it's a strawberry Pop-Tart. And I was like, so... and the kids turned to the mom and said, I think I'm a boy and the girl's covering me up. And the best thing was that the mom was like, oh, just got up and gave the kid this big hug, and it was an amazing experience. But I think it was like this kid, and I worry about when we say things like, I am a versus I wish I were a, because I think that there's so many things that contextually happen for people around the way they understand and language gender. So I don't think I made this kid a boy. I don't think so. I mean, and if I did and I'm wrong, I'm totally going to come to this conference and tell people that I was wrong. I will. But I think that giving this kid the language to talk about his gender was really important. It actually did not make him a boy. It gave him language to understand his gender.
Keep in mind, Olson-Kennedy was asked by an enthusiastic person at the conference to tell this story, and the audience loved it. This Pop-Tart analogy, which she's now teaching to others, tells a child that her body is wrong, that it's simply incorrect and mismatched, just like a Pop-Tart placed in the wrong flavored box. She's encouraging a mind-body split and a disconnect. In my view, this teaches the child to have body image problems and to engage in cognitive distortions. This is the very kind of split that people spend years trying to heal after they've experienced trauma or abuse. Why? Why instead wouldn't she just explain that the girls in the bathroom were wrong? That just because this girl has short hair or certain clothes, it doesn't make her not a girl, even if she looks a little different from her peers. Why instead wouldn't she encourage the mother to take this up with the school to ensure that they have safe and actually inclusive policies for all their students? In fact, the child had it exactly right when she said, I'm a girl because I have this body. So how distorted does your thinking have to be to look at that little girl's situation and conclude that she's somehow actually a boy that was somehow born into the wrong sexed body? That her body has nothing to do with her identity and that her body just doesn't matter. I think this is a metaphysical belief and not a reality-based way of understanding that little girl's experience. All right, let's look at false assumption number 3, the Dysphoria Physical Disease Model. Bodies that clash with identity must be corrected. So the issue of mental health is front and center in Clementine's case. The difficulties she was having before she came to the gender clinic were never really asked about or addressed. And as we'll hear next month, her mental health severely declined after these gender interventions. And all of that was completely rationalized away by her providers. But why wouldn't a young patient's mental health be considered important when providers are recommending the most consequential intervention conveyor belt known to pediatric medicine? Olson-Kennedy was actually asked about this back in 2018 by Jesse Singal for his groundbreaking piece in The Atlantic. She told him, "I don't send someone to a therapist when I'm going to start them on insulin." I think that's an absolutely crazy comparison, but that single statement really demonstrates the false assumption that we're talking about here, that the body is diseased and must be corrected right away for the health and well-being of the patient. Let's look at another clip of Johanna Olson-Kennedy.
This is other baseline data from the young people in my practice, and this is talking about sort of the other mental health things that are happening for people. So 30% of my sample had moderate to severe depression symptoms. Thought about suicide, 49, 51%, and attempted suicide over 30%. And a lot of drug use. I mean, it's LA, I'll give you that. A lot of kids were sexually active, and then not an insignificant number, 9 of my kids had actually done sex economy, sex work for a place to live or something to eat. I didn't actually show you in this slide, but a lot of the young people in my practice experience homelessness, precarious housing, and they've been in foster care.
Later on in the same clip, she brings up what she calls the hot topic of gender confirmation surgery in minors. She explains that this is coming on the horizon and even makes a joke about how all of the audience's kids are probably going to ask them about surgery after they've attended this talk from Dr. Joe. Dr. Joe is the nickname that her fans affectionately use for her. Anyway, she goes on to contrast mastectomy, which she calls chest surgery, with genital surgery. Let's listen.
Chest surgery for trans guys as minors is critical, and it's available. It's not nearly as difficult as genital reconstruction because it doesn't have anything to do with sterilization. The difficulty of genital surgery is that it is surgical sterilization, and people get super worked up about that. And that is the barrier that we have to overcome, and I think we're going to. But chest surgery is not that. It actually isn't. It's a very easy, safe, relatively fast procedure that is absolutely life-saving.
Notice how she put the word sterilization in air quotes? Notice how she said people get super worked up about that, and how that's a barrier we have to overcome, and I think we're going to. This perspective is alarmingly disconnected from reality. Next month, in our second video in this series, we're going to explore some of the more personal content in Olson-Kennedy's life that might explain some of these distortions that we just heard. But for now, I want to engage you in another brief thought experiment to help us understand this mindset. Let's say you're a physician who encounters an adolescent boy who is hungry, homeless, and very depressed, who also happens to have diabetes. Giving him easy access to life-saving insulin is the least you can do to improve his well-being. Well, what if that's exactly how you thought about alleviating gender-related distress? When a teen's uncomfortable with her biological sex, even if it's just for fleeting moments, is a marker that she is in fact trans. What if you think that is as valid as evaluating a patient for diabetes using a blood test? What if you thought gender identity self-report is just as reliable as blood work? I mean, if gender dysphoria is the same thing as diabetes, and the treatment pathway is easy, safe, and absolutely life-saving, why wouldn't you recommend hormones and surgeries? Maybe that's why Olson-Kennedy thinks that fertility is so inconsequential and talks about it in the very flippant terms we just heard. Preserving life itself versus fertility. Seems like a no-brainer from that perspective, right? Helen Joyce, in the brilliant way she always does, explained this well in a recent conversation with La Leche League founder Marian Thompson. In discussing the idea of a trans woman, which is a male who identifies as a woman, she said something like this: If you manage to get this crazy idea in your head that it's possible for a woman to be born with a desperately tragic birth defect, which is that she looks exactly like a man, then you would do anything to help that poor, poor woman. Olson-Kennedy seems to believe precisely this, and in this case, about Clementine having been born a boy with a tragic birth defect of looking just like a girl. And there's that false assumption. Bodies that clash with identity must be corrected. And so, Clementine, at age 14, underwent a double mastectomy with Dr. Mosser, who apparently didn't even meet with her until the day of surgery for a quick 30-minute exchange. There is so much more to say about Clementine's lawsuit and story. So in February, we'll look at what happened to Clementine after hormones and surgery, and how the gender clinics make sense of mental health complications or worsening outcomes after these supposedly necessary interventions. If you're watching this on YouTube, please be sure that you are also subscribed to my Substack, because that's the only place to get the rest of this month's newsletter. And in my newsletter this month, I make a huge announcement about Gender a Wider Lens and the launch of my new solo project. I also talk about the death of music genres, which is a topic that went viral when we had an interview with Dr. Az Hakim. And I describe my latest video about the return to a birth sex identity, what the data says, and what patterns to look for. You can also check out the parent questions that I answered in last month's live Q&A and much more. Thank you so much for watching, and I'll see you next time.